Matthew Perry, how are you today?
Hey, Brienne. I am doing very well today. We have a kind of gloomy day here in San Diego, but that's okay. This conversation is going to brighten things up, right?
Awesome, awesome. And like we said, or like I said off air, you can keep it in San Diego because I don't want it, and I know it's coming here next.
It is it is a move-in.
And this is very odd talking to you at what almost 5 o'clock my time when we normally talk at like 8 o'clock in the morning.
Yeah, it's like almost bedtime for us.
That bit true. After this, I'm gonna go make dinner and pretty much go to bed afterward.
That's it. But always good to be on here.
Absolutely, absolutely. So let's what we're kind of brainstorming today was just really kind of talking about the stuff that they don't teach us in school, whether it's overlooked, whether it's stuff that we just have learned since is kind of debunked. So we kind of want to dive into some of those topics today. And I think starting with what I know we've mentioned on here in the past, at least in passing, but kind of some of those things that are traditionally used for recovery purposes, or dealing with injuries, like using braces for long periods, using ice and heat, like all the things that I think are just overused and may or may not have a whole lot of benefit when it comes to the healing process.
Yeah, those are some things that are fairly ubiquitous in our society, right? I don't know about you, but like most people who come in to see us, when I ask what have they been doing to help out their injury before they came to see us, and about 100% say ice. I think the tens units are making a huge, I don't know, comeback, or I don't know if this is their first wave or second wave, but I know everyone has one of those now.
True. Yep.
And let me start by saying, like, I'm really happy that almost all the people who come in to see us, are trying to do something to help themselves, right? Like, let's definitely start with that. Like, awesome. You've done everything you kind of know of. You've done the Advil or Tylenol and the ice and the heat, the TENS unit. One of my patients bought a whole body vibration machine to try to help with her stuff. And that's great. They've reached the end of their road and they're in maybe knowledge base and are now coming to us. But there's a lot of times I really wish that those weren't the first things that we went to. When something hurt. Ouch, let me take a pill for it. Ouch, let me throw some ice on it and magically it'll get better, right? I mean, it's kind of
Yeah, and
interesting.
what comes to mind as you're talking, and I think part of this is just our medical system in general. My stepsister's been dealing with a bad back injury, like hasn't been able to work for several weeks. Um, and this all started several months ago when she started having pain. She went to saw a therapist who did like the soft tissue work, the like just all the manual therapy, all the modalities. Didn't really teach her anything on how to move differently. Fast forward a couple months and she can barely walk now. And is living with all this stuff, goes to some pain doctors and some neurologists, and it's like, oh, here's some pain medication and some antidepressants and some anxiety and all these pills. Where when then it's like she's doing her own research to like who are some good therapists in my area, who knows how to treat back pain, and asking me all these questions on what should I be doing. And I think it's just this disconnect that's also present in our medical system, that's like people are doing these things because they don't have any other options, because everyone else that they're going to is telling them to do these things, or is telling them they're a malingerer or crazy, and they just have to like deal with it.
Yeah, it's that's a huge point. It's all these kind of band-aids, if you will, on an injury. In order to, again, like I said, like almost, I guess, spontaneously things will just get better. If we wait and see with some ice or some heat or all the modalities as you said. But that's not the root cause of what is causing their issue in the first place. or the problem that's keeping their issue consistent, before they come see us either, right?
Yeah, absolutely.
Yeah, so you know, it's this interesting thing, and I think a lot of medical doctors are advising their patients, oh yeah, just throw some ice on it, and see how it feels, see if it gets better, and if not, then we'll do some other things. But it's like, what are we really using the ice for, right? Because we know after an inflammation response, in that first, what is it, 48, 72 hours max,
Hmm.
that the ice most likely isn't doing a whole lot of good, as opposed, aside from burning and cooling cooling the area. If it's a hot day, that's fine, but outside of that, there's not a lot of therapeutic use. So I don't always like that people go to that, especially in a chronic condition, right?
Absolutely. Even the acute condition, I mean, I understand people use it, but you and I both know like swelling is what brings the healing properties to the area. If you don't let that swelling be there, then the healing properties aren't going to come. So it's really not going to heal anyway. So even in the acute phase, like it's not necessarily one of the things you want to be doing all the time.
And that's a huge point. We dog the I word, which is inflammation, right? Like inflammation is a bad thing, that you can't have any of it in your body. If you do, it's bad. I mean, right? Like that's kind of
Oh,
what
absolutely.
our society is kind of going towards. But we need inflammation to heal,
Mhm.
right? And if you do not have, the macrophages and cytokines and all that kind of stuff, working, then your tissues can't heal. And sometimes when you take things like NSAIDs for long periods of time, it decreases your ability to heal.
And that's a great point as well that I think a lot of people overlook because how many people, I mean, I know a lot of people who just use that stuff as candy, basically. It's like, or, they call their pre workout because it's like, it's how they get through the day or it's how they get through, like, how they function. And while it can be amusing to joke about, like, it's not the best way to live because, yeah, like you said, it decreases our healing response.
Yeah, and so I really wish we would make a shift to, educating people as to why you would ice something, or
Mhm.
why you would take the NSAID, as opposed to just take the NSAID. I think we're missing just that little piece. Because I mean, we also don't want people to start masking things too.
Mhm.
I know we've talked about that in the past, and your pain because you have a torn or ruptured, partially ruptured something, is a 10 out of 10 for a reason, because your body's like, leave it the heck alone. And now you take your NSAIDs or your Vicodin or whatever, it feels like a 2 and you're running on it. That's not a great thing either.
So on that note, what is like, I know everyone, like every case is different, but as a general, what's your suggestion for when it is okay to use pain meds or anti-inflammatory medication?
Great question. I would say if it is a very acute issue for someone, or even chronic with an acute flare up, I think we should definitely take it if it's affecting our sleep, if it's affecting our ability to do our, ADLs, those are activities of daily living, be able to, play with your kid, and, those kind of things in the short term. Um, but, outside of that, I don't see a huge indication for it personally.
Yeah, and that's I'm kind of the same way. Like my big one is always sleep because sleep is when our bodies heal at its best. And so if we can't get quality sleep, then we aren't going to heal regardless. So sleep is always a huge one that I'll recommend taking. And then, yeah, if you need it to like, if you can't do your job or take care of your kids, then I think it's a good idea just to at least use it to get through your day and sleep. But yeah, definitely not to the point of masking it.
Yeah, absolutely. One of my patients, she's actually very anti, medications and stuff like that, but she was just having this very acute flare up. Her husband had been working in like some of the COVID wards here in San Diego, and so needless to say, he was putting in, some big time there for a while, and they finally had a trip to Disneyland, and it was like in a couple weeks, and she just wasn't healed to the point where, she really, should be doing it, but it's like, who am I going to say don't go to Disneyland with your family and, and enjoy yourself? Cool. Take some ibuprofen, and then I'll see you next Monday, and we'll work with the fallout.
Right? Exactly. Fun is necessary.
Yeah, absolutely, right. It's the mental health and having fun, if nothing else is detracting you from your pain, especially if you have chronic pain. So I know we know that.
Another, just something else, and part of this is something from a conversation this weekend that I was having, is that I think, as you and I know are good at like talking, when explaining, asking questions, treating people as humans, not as a diagnosis or not as just an issue that, an issue that's causing pain, whatever.
Yeah.
But I think so many times, whether it's all areas of the medical field, I think it's like we almost just we don't see the person, we just see this diagnosis in front of us that needs to be treated, and we look at the images, we do all these things and just see like, okay, this is why the pain's there, this is what we need to fix it, and we forget that there's a human being inside that, or encompassing the pain. I don't know how to
Yeah,
word
yeah,
that.
yeah, yeah,
But
yeah,
a human being right there, not just this diagnosis.
yeah. I mean, it's a pain is, as we've said before, it's such a complex thing. It's almost its own being. You know what I mean? Or it can be for some people. So if we are seeing our person, because we got the MRI report before the evaluation, before we even talk to them, that they have degeneration in their knee, guess what? Our odds of having that bias of this person is, the degenerated knee patient, is a lot higher, right? And I don't necessarily say that I never look at images before before seeing someone, just because I want to make sure I'm doing my due diligence and making sure they're a good candidate for physical therapy, or do they need to go elsewhere? But we can't let that diagnosis drive our car when it comes to us as clinicians to do a full subjective, really get to know the human behind that diagnosis.
Absolutely, because we never know. I mean, every person heals differently. Every person responds differently. Their mental state and how they view the issue is going to play a huge role in how the body responds. And there's just so many factors into it that we can't just assume every diagnosis is going to be the same.
Yeah, I mean, like let's take a huge zoom out on this, and let me ask everybody, including you, Brianna, but everybody listening, what is a 10 out of 10 pain, and what does that feel like? That is one of the most subjective things, that we have as humans, because it's different for all of us. Mm-hmm. People who have experienced childbirth, I hear that's a 10 out of 10 pain. But what about the person who got in a traumatic car accident? That sounds like a 10 out of 10 pain too, right? And whose is worse and whose is better, and and all of that. So, I think we need to understand just how subjective all this stuff can be, which is why we got to treat person, who is it? Aaron LeBauer, I believe, name drop. I treat patients, not insurance, right? Mm-hmm. I love that line. So shout out to him. Hopefully you get him on the podcast at some point.
There we go. I used to, when I worked in the insurance world, because they like those pain scale numbers, I would always ask people, and they would tell me, I was like, okay, so a 10 out of 10 is you've just been shot. Is your pain still a 10 out of 10?
Have you seen the graphics of 10 out of 10 it's the image of a bear mauling you with bees around it?
Yes.
Exactly. So, I like the idea of the VAS, which is that, kind of 0 to 10 scale, for this person specific, how we can maybe measure improvement. Mm-hmm. Because if they're self-reported 8, or at a self-reported 8, and then a week later they come in and now they're saying, oh, it feels kind of like a 3 or a 4. Cool, that's a difference. Am I, you know, taking a whole lot of weight in it if they say it's a 7 instead of an 8 today? Like, no. But a 4, that's pretty significant. It's 50%, right?
Yeah, absolutely. And on a yeah, and that's where it can be tough. Like it's a great thing to use for just to get that perspective of is progress being made, but to to base all your decisions on that is definitely not appropriate.
No, that absolutely not. And speaking of, kind of just this whole thing of pain masking and due diligence within the healthcare community, you know, I find that we might be a little bit quick in a lot of cases to start masking that pain ourselves as clinicians, meaning, first session, throwing some ultrasound on it, right? Or the laser or the infrared light and all that kind of. I'm not knocking any of that. I've seen all of that stuff work in various instances, but let's look at the cause of it first, and then we work on the kind of the palliative part.
Yeah. Well, I mean, let's look at this. Like, do you own any of that stuff?
No.
Exactly. Do I? No. And do people get better? Yes.
Yes.
So is it necessary? No.
Absolutely not. And I know people who run their whole practices on it and all that kind of stuff. More power to them and all that. But people, for the most part, at least in our realm, musculoskeletal realm, they need to move to get better. I would say in most forms of healthcare, you need to move to get better, whether that is oncology or other facets of the healthcare system.
Absolutely. And and not to say all the modalities are worthless. Like there is a time and place for them. Like I use needles to do it, needles and stim to do it, but I'm like after a muscle tear to get muscles refiring again, like and get fibers realigned, like can be helpful. I just did that again today with one of my patients, like can be helpful. Ultrasound's great for diagnosing stress fractures because of the vibration.
Ouch.
So like
I felt
that I
that.
don't find benefit, but
That's
I use a
funny.
tuning fork, but ultrasound works too.
To each their own. I mean, you can use a $10,000 machine or a 50-cent tuning fork. Maybe $1 with inflation. Who knows? But it's yeah, so and that's a great point you kind of brought up. It's like, well, why are we doing the things that we're doing? And if there's a reason for it, that's great. But I bet a dollar to a donut, Brianne, that not everyone who comes in contact with you gets needles and just gets these things just because you got them, right?
Oh, not at all. Not at
It's not
all.
it's not burning a hole in your pocket if you don't use it on people.
I don't use everything on everyone. Everything has its time and place.
Everything. Except for those little ring bands. I don't know. I kind of like throwing those on everybody just because they're diabolical. People look at me like I'm crazy. I don't know what they're called, but you know what I mean.
Yeah, I know what you're talking about. Yeah. Oh my gosh, that's funny.
But yeah, we what is it called? The study of epistemology, right? It's not just that something works. It's like, why does it work, and why are we doing it, and why, et cetera, et cetera. The layman person can definitely go online, buy an ultrasound machine, and just lather themselves up and go to town. I don't recommend or nor advocate that, but they could and not understand what's going on with it, and that's totally fine. We as clinicians need to do a little bit better than that.
Absolutely, absolutely. And you're right. Like, we. I think the recent TENS units a lot of people have is because they're now on Amazon. You can get them super cheap. Which same thing. Like, if you want to do that for controlling your own pain, totally cool as a consumer. But yeah, as the clinician, like, we need to be better.
Yeah, yeah. You go to some of these, and not knocking them, but some of these big box clinics, and I am knocking the ones who do this, and you'll just see rooms and rooms of people with their little like TENS unit and ice, and they're billing time for that, which is a burden on on the healthcare system and all of that kind of stuff, which is contributing to reimbursement declines and people needing to do that more and more in order to have a functioning clinic. So we again just need to have a purpose for it and stick with it. We shouldn't have a room full of ice and tents unless
No, not at
unless
all.
your clinic is called Ice and Tens and you're not billing insurance and everyone knows what you're doing. Maybe that's a good business model.
Or that.
Or that. I'm just kidding, everybody.
Oh my gosh. Where do you go from here, Matt?
Who knows? I think we solved all the world's problems personally. I think that was it. We won.
That was. Totally.
um, but no, I mean, like the overall theme with this is, that we're kind of talking about is like things they don't teach you in school. I think, kind of that's where we started. And yeah, I would love to see some physical therapy curriculum, one that's not 20 years old in schools, and also one that's talking about other alternative modalities besides ice, besides ultrasound, because that's all I got in school
Mhm.
was, oh, if something hurts and they come in acute phase, ice and ultrasound, and then maybe we'll do a little bit of, some elbow flexion passively for their elbow and, whatever. And you're finally on stage 17 and then you're finally like loading them, right? We know that for the most part in the body, they should probably be appropriately loaded as that phase 1 or 2.
Mhm. What's your thoughts on, I feel like we've talked about this before, but I'm not totally sure on that. What's your thoughts on like stretching and just how, like, I guess how often it's used? How often is it actually necessary to be doing?
Yeah, that's a huge point of, we'll say maybe contention in the health and fitness community. And that is another kind of default that people go to, right? Oh, what have you been doing for your, shoulder? Oh, I've just been stretching it. I've just been putting it across my body and like over my head like that. And I personally am not a huge fan of stretching. There's a time and a place for it, for sure. But most people come to me thinking that they're tight because their bodies just woke up one day tight, but there's some significant muscular imbalances going on. And I've had the most effect by not necessarily stretching the tight muscles, but strengthening the antagonist muscles or re-coordinating them, neuromuscular education, whatever you want to call it, to those muscles to turn them on to help bring them into a better position.
Yeah. How often are you getting people who have seen other therapists and were given all the stretches?
Yeah, every single. That's a loaded question.
Yes, it was.
Yeah, very much so. Yeah, I mean, every single person comes through the door. And so, that puts me in a good position because I'm like, okay, well, if you would like, continue doing all of that stuff, but we're going to do some other things. I'd like you to prioritize the things that we're doing, and see how things are going. And guess what? They've been going to see someone elsewhere for 4 or 5 months with no change. When we start introducing some of these strengthening, quote unquote, strengthening exercises, they start getting better.
Mm-hmm. And I yes, it was a loaded direct question, but just going back to that whole like curriculum, like where do we learn to stretch every tight muscle? Like obviously most therapists know this. As a young therapist, me coming out of school, I mean, I came out of school a lot longer ago than you did, and it's like that's what we were taught. Obviously now I barely have people stretch, but it's another one of those things that's just it's what the traditional models do, and it's not really people aren't getting better that way. It's not the most beneficial thing to be doing.
No, not at all. I mean, if it was truthfully, then most people could go right on YouTube and heal themselves of whatever musculoskeletal ailments they have, right?
Mhm.
Because there's tons of stretches, no shortage of them. And that's what I tell my patients too. I'm like, hey, if you want some stretches, I'll guide you through some stuff, and or you can go on YouTube and find some stuff, and I'll vet it, of course. Um, but yeah, I think we were taught anything that was tight, you stretch it. Anything that was tender, you kind of stretched it because you didn't want to strengthen it. Because if you did, that'd be too much for the system, and you fail the practical, which I guess meant hurt the patient, kill the patient. I don't know. I'm just kidding. We're not killing our patients here. It was something bad and diabolical.
Right, exactly. But
So,
yeah, like it is, we learn, like, as a general, you learn to stretch it if it's tight, strengthen it when it's weak, and move it if it's stiff. Like,
yeah, yeah. And you know what? Like maybe we can extrapolate. I don't think this is where we're going with it, but you know, strengthening is some form of stretching, right? Through an eccentric contraction, and I mean, these things are happening. They're just not happening with the, bring your ear to your shoulder and hold it for 30 seconds or whatever, right? Um, you're getting the desired effects, probably in a more effective way.
absolutely. You made a great point there, because and yeah, and a lot of it is terminology and how you're doing it, because I do have people do a lot of active stretching, which is that eccentric, the controlled elongation, really learning how to control that motion as you're elongating the muscle. Um, but yeah, not necessarily the passive holds.
Yeah, the passive holds, and it's interesting. They're now doing some research. I don't know if you saw that one, and I don't have the data in front of me, but they did it on runners, and they had some statically stretched, they had some dynamically stretched, and they actually found a increase in injury for the people who statically stretched. Right? You've seen that?
I've seen some studies on it. I'm not sure if I've seen the most recent one that you're referring to, but I definitely have seen that. Yeah.
Yeah. So it's that's interesting. And so the things that we've been doing previously, like, were great up until we found something better.
Yeah.
And some people are still stuck back then because it's easy and it makes sense and all of that, but we're advancing, which is a great thing. I love the people who are talking about squatting knees over toes, like that, because that was such a, you know, oh my gosh, if I did that in gym class, like they'd have my head. But now we're like, hey, maybe that's not a bad thing in certain situations, in certain cases.
Yeah. It's funny you say that, because I was thinking I was trying I was gonna write a post and I couldn't really figure out how to make it sound good, so I never did. But um like how think about the psychiatric people, how like lobotomies used to be a normal thing, and like insane asylums, and like all these things used to be the standard, and now it's like, what, WTF, like we did these things. um and like I feel like that's where a lot of things are going in the rehab world, which is great. Like we need to adapt as new things are found, but I feel like it's not going that direction fast enough. Like there are some people, you and I, who have adopted a lot of this stuff, but then we still have all like hundreds of thousands of clinicians and coaches and athletes still doing all of these other things.
Yeah, and it really is a shame because we're almost indoctrinating kids like now into this kind of stretching solves all my problems routine, in gym class and all that, just because it's archaic, and I'm not even sure what the evidence even was for some of this stuff. Kind of quote unquote science, and we can try to be vehicles of change, and that's why I love what we're at least attempting to do here, because at the end of the day, it's not about what makes sense or feels comfortable for us. It's about what is going to get the patient better. And if that person who has their whole practice on modalities, needs to get rid of $200,000 worth of machines and stuff to help their people better, that might be indicated, right? That might be the right thing to do.
Absolutely. And even like I've talked to two different podiatrists on my podcast and who started out as doing the whole traditional thing, orthotics for everyone, and like started doing their own research, looking into things. You're like, why am I doing this? And even myself, like as a younger PT, I was doing orthotics for people. I was like doing all that stuff. And over time, it's like we learn, find research, we figure out what things do, what the body does, and we adapt. And I think just not an and I don't know if it's an ego thing. I don't know if it's just people don't want to change what they're doing. It's hard saying the reasons behind things, but I think there's something to be said about just being willing to, what, this is what I was doing. This is what I know now. Let's go this new direction.
It's that simple, right? And I know it's more complex than that, but I mean it is when you boil it down simple. And that makes you a bad person because used to do in orthotics and all that stuff? Absolutely not. Did it make me a bad personal trainer before PT school because I would have people stretch? No, but we learn and we grow, and we are better off from it. So, that's the big thing, and kind of calling out our profession. Like we call ourselves an evidence-based profession, but I wish we would get a little bit more with the evidence.
Yeah, I agree.
Sorry, everyone, for that rant. We need something a little bit cooler because I was getting a lot hot. Thanks for bearing with us, y'all. This is important stuff, though.
Now the rant's over. Where should we go with it?
Yeah. And so another, kind of thing about, what they didn't teach us in school is like, to your point in the beginning is, the fact that we actually have to talk to somebody and, and, kind of meet people where they're at, and not everyone is a multiple choice test where there's a clear right or wrong answer. And there has to be this critical thinking in the profession, well, everything in healthcare, because rarely, I have had a couple people who fit the textbook to a T, but that rarely happens.
I was just going to say, you mean no one follows my textbook? I don't get it.
Come on. Get with the program, y'all.
No, that's absolutely right. Like, yeah, I mean, every once in a while you get someone who like follows exactly like that shoulder impingement presentation or, whatever. But yeah, more often than not, when you start having conversations with people, like you start picking up on other things. And along with that, like, I think we forget how much like those injuries 10, 15, 20 years ago play into present day injuries and issues. And if we don't really take time to find out the history of someone and find out, what, I fractured my ankle 20 years ago. And like, you may never, like, if you don't find that information out, you may never really get to the conclusion of things.
Because yeah, you never dove in deep enough. And there are a lot of times I loved that ankle injury like 20 years ago, because there are tons of people who come in, with back pain or like whatever, and I'm asking them questions like, no, I've never really had it before. Oh, well, I did used to like jump off roofs back in college, just onto the asphalt, and I fractured my legs a couple times. And it's like, oh, well, how many times? Oh, well, like 4 times, and I've had surgeries from it and been in boots, and now they have all these imbalances. I'm like, okay, painting me a picture, thank you. Now we go for the lower body and correcting gait and all that stuff.
Mm-hmm. Yeah. I had one years ago, once again, was in the insurance world, low back pain for several months, and ended up like through that conversation, she had a huge abdominal scar from a surgery like 20 some years ago. And other, like, yeah, we did some strengthening work, but primarily it's like we just worked on that scar tissue because it was so adhered down. It was impinging everything. Like once that was loosened up, her pain like was like melted away. And it's like if you like you could do all you wanted to the back, but it wasn't gonna solve that problem.
You could use every technique in the book for the back, and that probably wouldn't have changed the outcome. Um, so that yeah, that's a perfect testament to what we've been saying. So yeah, everyone who's new out there, and I'm new, but newer. Um, we're always constantly learning. Really, make sure that you don't see your person as that number or that ailment and all of that, and you're going to go so much farther.
Yeah, and I think
I'm sorry.
oh, go ahead. I was just gonna say another thing too that just like conversations that have come to mind more recently is like life changes as far as like um someone I've talked to someone recently started having hip pain. Well, he's 14 years old, he's grown a ton recently. Like what's possibly hasn't kept up with the other as far as growing has come. Like women going through menopause are more likely had to have joint and muscle soreness. Like we can't discount like life changes as we go through the different stages that like hormones change, muscle to bone length changes, and like all these things play a factor into why this person might have pain right now.
Hmm. And that's a great point of, I like to use like it's a calories in versus calories out analogy. Like it's so simple. Oh, whatever you put in your mouth, and whatever you expend equals, your weight gain or weight loss. There's a million processes that happen, probably more than a million, in between when that piece of what food goes in your mouth and when it comes out. Just like with the human body, there's so many things that happen, have happened, will continue to happen that are going to change change a person's uh, life, whether it's injury or healing.
Oh, absolutely, absolutely. Do you think like when it comes to talking to patients, finding out history, finding out what else might be involved, do you think it's like lack of understanding of what all could be related? Do you think it's more of a time factor that people in the insurance world are rushed for time and evaluations? Like, what do you think is playing a factor in some of this?
Yeah, I think it's a little bit of all that. I mean, obviously, time constraints are worse than they've probably ever been in the healthcare system. So that's a huge factor. But I mean, also, you know, and we do it here too, which is wonderful. I just do it all day in my life. I think there's so much value with my patients, at least with some of these tangents and getting off topic and exploring kind of some of these other things that have nothing to do with their back, because I gain so much clearer of a picture than if I were just to ask them, oh, okay, when the knee pain start hurting, when that kind of stuff, the straight subjective stuff, because I feel that the patient will always tell me what's wrong with them. It might not be in technical terms or anything like that, but they'll let me know because they're feeling it.
Hmm. Absolutely. And I think through those conversations, like even if you don't specifically, we all forget to mention things. Like even if something doesn't feel someone may not think something's relevant, so they may not mention, you know, they broke their toe and when they were 5 or whatever. Like just may not mention things, but then through conversation, things gradually come up, and then it's like, oh, well, this could be related to this, and this could be why this is still happening. And yeah, I think it's just so important both at that first time you meet someone, but also throughout the time you're working with someone, just continue to have those conversations and just really get a good understanding of like what's going on with them as a human.
And that relates perfectly, just to that aspect of time, right? When you're spending an hour plus with someone a session, you have a more of an ability to peel back the onion, because yeah, it's all part and parcel. And I yeah, I think if we kept our ears open and our mouths more shut, as a not so good way of putting it, but you know what I mean. I think we can glean a lot more from our patients, even if we're with them for 10, 15 minutes.
Hmm. Yeah. And something that's coming to mind too with that is just thinking back to when I was in the insurance world and like how every minute had to be justified to the insurance company. And it's like, when you're talking, like sometimes you just need to talk to someone for 30 minutes just to either let them vent because all this emotional stuff is causing their pain to be worse, or you just need to get a better understanding. And it's like, it's hard to bill that, but it's necessary time.
Yeah, and hey, at the end of the day, patient education, right?
I know, right? Exactly.
I don't know what that reimburses for. I'll never know, but still. um, yeah. I mean, it's all skilled, right? Because they're not speaking to their daughter or whomever, right? Or parent. They're speaking to someone who has a expertise to kind of pick some of the stuff apart and figure out, oh wow, you broke your toe when you were 10 years ago. Okay, that can change things, and give me more insight into this. So, yeah, just, more time. I wish we could bring back a little bit more of that old school with the healthcare
Hmm.
and that family doctor who knows Mrs. Jones and all of her kids and all that kind of stuff, right?
If only, if only.
One day, maybe we'll have more of a renaissance in this healthcare field.
Just have to have a rebellion of some sort. Not sure.
Something like that. I was trying to put it a little bit less inflammatory, but yeah, something like that. I agree with you.
All right. Anything else you want to bring up tonight?
Whew. I don't know. Like I said, I think we solved all the world's problems
We did. Record
earlier,
time.
and no, that's kind of it. I think this conversation. I mean, a lot of all of our conversations have been great and significant, but this one in particular has kind of resonated with me a little bit more because it's it's all the things that you and I are definitely trying to change in the healthcare system, right? People are truthfully getting fed up with the impersonalized care they're getting from top down, and that's from every practitioner there is. And so I love that there's all these people trying to change the game, and again, no shame for the people who are still in it, because I know a lot of people who are still in it don't like it, but they have to be there for one reason or another. I feel it, but we just need to keep pushing, and we need to keep pushing our profession to be better, and the whole healthcare system in general to be better.
Yeah, absolutely. Good closing statement there.
Thank you.
If someone wants to talk to you, ask you questions, yell at you, etc., where can they find you, Matt?
Well, if anyone wants to, I guess, do any of that, they can find me at AutoNest Physical Therapy. You can Google us. We're also on social media. AutoNest Therapies is our Instagram handle. And but send the hate mail, of course, to Brianne, as always. But no, in all seriousness, I'd love to have a conversation with anyone who, where this struck a nerve one way or the other, and see if we can have a healthy conversation. Maybe get them on here and we can, talk it out.
Awesome. Well, Matt, thank you for your time. I mean, always fun to have a conversation with you.
Thank you so much for having me on, Brianne. I appreciate it as always.